All right. So it is my great pleasure to introduce Dr. Luciana Chamie. I didn't get that right, I know. A radiologist specializing in female pelvic imaging and endometriosis. For over 20 years, she has been dedicated to the diagnosis of endometriosis and infertility, performing more than 50,000 specialized ultrasound exams and countless MRI reports. She founded a private practice 15 years ago focused on the diagnosis of endometriosis through advanced imaging and has served over 2 decades as a senior radiologist in Sao Paulo, Brazil. Incredibly prolific in her academic and advocacy work, she has improved outcomes for patients with endometriosis through early detection and precise pre-surgical planning. She has delivered more than 150 lectures, published extensively, and contributed to the scientific committees of leading societies in radiology, minimally invasive surgery, and reproductive medicine. She is currently a postdoc research fellow at the Center for Evidence-Based Imaging at the Brigham Women's Hospital in Boston. Her work reminds us why increasing research, expertise, and resources for endometriosis is so essential. Despite affecting 1 in 10 women, endometriosis remains underdiagnosed, undertreated, and underfunded for research. Improved imaging and clinical awareness are critical to reducing diagnostic delays and ensuring timely, effective care for patients navigating this often debilitating condition. So please welcome, and please join me in welcoming Dr. Chamie.
Hey, good morning, everyone. First and foremost, I would like to thank Dr. Powder and the OBGYN department for the kind invitation. It's an honor to be here with you today. So in the next 40 minutes or so, I will be conducting a deep dive into the universe of the imaging diagnosis of endometriosis, one of the most important gynecologic disease and the main cause of female infertility. I have no financial disclosures. So I will begin my presentation telling you a story. This is Kelly, a 38-year-old woman complaining about infertility for the past 3 years, dysmenorrhea, and deep dyspareunia. And to better understand her complaints, let's take a look at her gynecological background. So she had her first period at the age of 13. At 15, she started using oral contraceptives due to acne, cramps, and a diagnosis of polycystic ovaries. She kept on using it continuously and performing her annual checkups without abnormalities. As a lawyer, she focused on her career. And at 30, they got married. So 2 years later, the couple decided that it was time to have a baby. So she quit using oral contraceptives after 16 years using the medication. And after 6 months, she started having pelvic pain and deep dyspareunia. After 3 years of unsuccessful attempts and having visited 3 different gynecologists, she decided to see a reproductive endocrinologist. And then he asked for specific exams, a hysterosalpingogram, which demonstrated dilated and elevated tubes, and late contrast retention. This is a very important finding associated with adhesions. And then a transvaginal ultrasound after bowel prep, and that's how we met. She had severe endometriosis affecting the anterior and posterior compartments associated with adhesions. And then her doctor suggested surgery or an IVF treatment. So this is the most common clinical scenario today in patients with endometriosis, the long use of contraceptives, and women delaying pregnancy for over their 30s are associated with the late diagnosis of endometriosis and infertility. Long use of contraceptives mask completely the disease, and the lack of specific exams also contribute to the late diagnosis of endometriosis and infertility. So this is the most common clinical scenario for those working with infertility and chronic pelvic pain. And endometriosis can present a wide clinical spectrum with multiple phenotypes, but chronic pelvic pain, dysmenorrhea, deep dyspareunia, and abdominal bloating. Abdominal bloating is a very common complaint, are the most common complaints around endometriosis. And there is no strong correlation between symptoms, severity, and extent of disease. No effective screening biomarkers throughout the years. Over 200 biomarkers have been tested as a screening test to diagnose endometriosis without success. And as we don't have the same treatment for all patients, treatment should be individualized and personalized. And that's why Imagen is so important in this clinical context. So we are facing a chronic disease that will impact women from the very early stage to the menopause. And we're going to follow these patients throughout this journey. Imaging studies from adolescent to the postmenopausal period. So let's review the basic concept of the disease. Endometriosis is defined as endometrial-like tissue outside the uterine cavity associated with inflammation and fibrotic reaction, extending on or under the peritoneal surface. We don't have the 5 millimeters cut off anymore. So any plaque or small thickening located on or under the peritoneal surface can be an endometriotic lesion. And this concept has been updated. Now endometriosis is considered a progressive and systemic disease with multiple inflammatory effects throughout the body beyond the pelvis. And why is so important to learn about endometriosis? Because it's basically an endemic disease. We have now around 200 million women affected. 1 in 10 women have endometriosis, and up to 60 to 7% of women, of infertile women. And the diagnosis is still a challenge in the clinical practice. It can take up to 12 years between the onset of the symptoms and the final diagnosis. And now we had an important paradigm shift. Now imaging studies are considered the gold standard for the diagnosis of endometriosis. There is no more room for a diagnostic laparoscopy. Diagnostic laparoscopy are now reserved for patients with negative imaging studies, with a strong clinical suspicion, or when the empirical treatment has failure. So imaging is really a revolution in the clinical management of endometriosis. Now we can provide a comprehensive mapping to help patients during clinical counseling, but basically for pre-operative planning. Our surgeons now, they are completely dependent on our preoperative mappings. They use our mappings during surgery to guide them during the procedure and also to prepare the multidisciplinary team. And why is that? Because many instances of deep endometriosis are hidden on laparoscopy, and even large lesions may be missed. For example, here you can see a huge bladder nodule infiltrating the detrusor muscle and also the anterior uterine wall. It is completely located underneath the peritoneal surface. And here it is a Brazilian group led by Mauricio Abrão, demonstrating that the dedicated ultrasound can replace diagnostic laparoscopy for the diagnosis and stage of deep endometriosis. And here you can see for bowel lesions, for example, it's a huge difference in sensitivity between ultrasound and laparoscopic evaluation, diagnostic laparoscopy. So we have 2 excellent imaging modalities available now: the transvaginal sonography after bowel preparation and the magnetic resonance imaging. The transvaginal sonography should be the first-line imaging modality. It's a cost-effective modality that can provide rapid results. It's a very powerful, I will emphasize, because it's a very powerful modality to identify, stage, and monitor endometriosis over time. It's a dynamic test. This is a huge advantage of ultrasound compared to MRI, because we can apply the sliding sign maneuvers And in my experience, transvaginal ultrasound with a dedicated protocol is a game changer, especially for surgical planning, for bowel lesions, to prepare the multidisciplinary team, and especially to diagnose small peritoneal implants and multiple bowel lesions. And here you can see the difference between the routine and the dedicated ultrasound. The dedicated ultrasound will focus not only on the routine evaluation of the uterus, endometrium, and ovaries, but also on all pelvic structures that can be potentially compromised by the disease. And we have a transabdominal and a transvaginal approach. During the transabdominal approach, we're going to evaluate the diaphragm, the perihepatic space, the hepatorenal fossa, the ileocecal region, the descending colon, the umbilicus, C-section scars, and inguinal regions. And on the transvaginal approach, we're going to include all the compartments and potential structures that can be compromised. And here, the bowel prep is crucial to optimize the results, not only to investigate bowel lesions, but to improve the overall view of the pelvic cavity by eliminating artifacts. It's a relatively simple bowel prep, includes the day before and the examination day. On the day before, they will take oral laxatives and keep a low residue diet. And on the day of the examination, they will apply one rectal enema up to an hour before the exam, just to clean the rectum. And then patient position is also very important. The pelvis should be elevated in order to allow free angulation of the probe into the posterior compartment. And the maneuver is key. Slide the probe into the posterior vaginal fornix in order to evaluate the posterior compartment. So here, transabdominal approach using the convex probe, we're going to evaluate the perihepatic space and the diaphragm. And of course, the best imaging method for the diaphragm is MRI, but using ultrasound, we can also identify hyperechoic plaques and also cystic lesions that can be associated with endometriosis. And then we're going to change the probe to the linear transducer and just follow the bowel. If they have bowel prep, you can see the bowel clearly here, and just follow the muscle layer because that is the most affected layer. And then we can also evaluate the umbilicus, the C-section, and also the inguinal region. And then the transvaginal approach. And for the transvaginal approach, we're going to follow an algorithm. And the maneuver is the most important point here, just moving the probe from the anterior to the posterior vaginal fornix. We can get very close to the posterior compartment and then evaluate lesions located in the heterocervical space, for example. Here is just an example on how you can improve images using bowel prep. Of course, for an experienced examiner, he can identify bowel lesions, for example, but if you add bowel prep, you can add details to your examination, like measurements and the circumference distance to the anal border. And then we have MRI. MRI is an excellent imaging modality. We have a multi-compartmental approach, a panoramic view of the pelvis. And here I will emphasize how important MRI is for the evaluation of the extrapelvic, extraperitoneal compartments, because using ultrasound, you have a narrow field of view. So when you add an MRI, then you will have a better evaluation of urethral neural involvement, malignant transformation, postoperative studies, and also for adolescents that are not sexually active, MRI is the best choice. But also for MRI, and here I think it's really important to emphasize, MRI is really, really susceptible to bowel movements, bowel content, and respiratory artifacts. So to have a nice quality MRI, you need also bowel prep. We do bowel prep for MRI. We do fasting vaginal distension with gel. a moderate bladder distension, and we also use antiperistaltic agents to avoid artifacts. And then we're going to use a protocol that will emphasize anatomy. So we need basically volumetric images, and we can shorten this protocol, especially for patients with claustrophobia. For example, we don't need a contrast to diagnose endometriosis. We just need good anatomical sequences. And depending on the patient complaints, we can add, for example, an MR neurography or urography to the original protocol. And here you can see the difference: no bowel prep and after bowel prep. So we can see the bowel layers when we do bowel prep. No vaginal distension, and here vaginal distension with gel. No antiperistaltic agents, and here after antiperistaltic agents. So you can improve a lot imaging quality. And then we're going to follow a multi-compartmental approach. In the beginning, we were dividing the pelvis in anterior, medial, and posterior. Now we added the lateral compartments. They are very important here. We have a lot of important anatomical structures in the lateral compartments, and also the extra pelvic disease. So moving on to imaging findings, the heterocervical space is the most common location of endometriosis, and where endometriosis usually starts in adolescence, in a subperitoneal location. And to evaluate the heterocervical space using ultrasound, we're going to just apply the maneuver, sliding the probe into the posterior vaginal fornix, and then evaluating the heterocervical space here. And then we can evaluate uni or bilateral involvement, lateral extension, vaginal infiltration, rectal sigmoid, a lot of important information here. And here you can see the normal aspect of the uterosacral ligaments. They are homogeneously hyperechoic surrounding the cervix. Here you can see the right uterosacral ligament and the left. And on MRI, you can also have a detailed evaluation of the heterocervical space. The normal uterosacral ligaments, they are regular, thin, symmetrical, 2 to 3 millimeters thick. And then you need at least 2 sequences with a peritoneal thickening or a nodule compared to ultrasound. So the main message here is, for small lesions, it's much easier to see small plaques using ultrasound compared to MRI, because on ultrasound, the normal peritoneal is hyperechoic and the plaque will be hypoechoic. And here, when you use MRI, mild disease will have the same color for the normal ligaments. That's why it's so easy using ultrasound to see mild endometriosis. And here, just to emphasize the anatomy of the lateral compartments, the parametrium and the extraperitoneal locations, especially the neural paths, is really important. And then any hypoechoic plaque, nodule, or tissue located behind the cervix can be an endometriotic lesion. And endometriotic lesions, they can present a wide imaging spectrum, varying from small plaques to large blocks of tissue. And here, 2 cine clips just to show you how easy it is to identify these hypoechoic nodules. We just have to look posteriorly. And here another example, hypoechoic thickening affecting both uterosacral ligaments. And this patient also has a huge bowel nodule here. And here, just one example on how fast you can diagnose endometriosis using transvaginal ultrasound, 9 seconds. It's like 12 years of waiting in less than 1 minute. And as an aside, so this is the rationale behind the SRU consensus. We published this paper last year. It is a multidisciplinary initiative to improve the awareness of endometriosis and the early diagnosis. We had a multidisciplinary team involving radiologists, MIG surgeons, reproductive endocrinologists, technologists, and the idea behind the consensus is to add, just in less than 5 minutes, we can add these two cine clips, a longitudinal sweep and a transverse sweep, and also a sliding sign maneuver, just to identify heterocervical disease in a routine ultrasound. Because our routine algorithm, it is completely different. We are never looking for endometriosis on a whole routine ultrasound. And then we created this consensus with the goal to improve the early diagnosis of endometriosis in the heterocervical space, because that is the most common location. And then patients can be directed to specific exams using dedicated protocols. So let's see if we can change this scenario. And on MRI, we're going to have the same presentation. Endometriosis will have a very repetitive presentation on ultrasound and MRI, very predictable pattern. We have a low signal intensity plaques affecting the both uterosacral ligaments, the torus uterinus, uni or bilateral with posterolateral extension. And here you can see a more like aggressive disease affecting both uterosacral ligaments associated with adhesions, affecting the bowel, and also bowel infiltration. So both methods are excellent. And what if we have a posterolateral extension? So when I'm performing this ultrasound and I have this huge nodule affecting the heterocervical space, I cannot properly evaluate the neural infiltration. Then MRI is the best method, is the best choice. As I mentioned, you can evaluate the heteroperitoneal spaces compared to the limitation of ultrasound with a narrow field of view. And we can also evaluate infiltration of the sacral roots, the pelvic floor muscles, and also neural structures. We published this paper addressing neural endometriosis. Now our surgeons, they are much more looking for information regarding ureters, nerves, and as endometriosis is very, very common in the heterocervical space, here we have the inferior hypogastric plexus. It's a very important plexus with a mesh-like configuration encircling the cervix. And when we have bilateral disease and large nodules, the neural plexus can be infiltrated. So bilateral disease is considered a severe case of endometriosis, and these patients will have an increased risk for postoperative complications with sexual, bowel, and bladder dysfunction. And also for somatic involvement, this is a typical case of a endometriosis affecting the sciatic notch. So MRI is the best choice. When the uterus is retroflexed, sometimes it's really difficult to assess heterocervical disease using MRI. And then using ultrasound, you can push the probe and pull back and then open this heterocervical space and identify heterocervical nodules. Another important pattern of endometriosis that I consider a marker for severe disease is when you have endometriosis deeply infiltrating the uterus from outside in. This is commonly mistaken as adenomyosis or external adenomyosis, but this is endometriosis. And the main problem related to this pattern is if surgeons remove this tissue completely, these patients will have an increased risk for uterine rupture during pregnancy. I've been following dramatic cases following many IVF treatments, and they had like a terrible complications. So now surgeons, they are sometimes they are leaving disease behind because they really need to keep the uterine structure. And then the last component of the posterior compartment evaluation is the famous sliding sign maneuver. When we apply the sliding sign maneuver on ultrasound, we can evaluate the mobility between the anterior rectal wall and the uterus. And here you can see an example of an abnormal sliding sign, because we have an endometriotic nodule here attached to a bowel lesion and obliterating the posterior cul-de-sac. Vaginal lesions are almost always an extension of a heterocervical lesion, and we can also evaluate the vagina using ultrasound. You just have to familiarize yourself with the normal vaginal wall. It's very thin, 3 millimeters thick, and then you can see when you have like an infiltration of the posterior vaginal wall associated with cystic lesions. And on MRI is also easy, especially when you distend the vagina with ultrasound gel. You can better evaluate the posterior vaginal fornix, and also when the fornix is obliterated. We can also evaluate the ureters using ultrasound. It will require a more experienced examiner, but we just have to mention the distance between the urethral path and the heterocervical nodule. We just ask patients to empty their bladder completely before the exam, and then they take 2 glasses of water, and after 15 to 20 minutes, you can evaluate the urethral path. It's amazing. And then just an example on a huge nodule affecting the heterocervical space and with a lateral extension involving the distal ureter. And we always perform a transabdominal evaluation to look for hydronephrosis. But MRI is the best choice for urethral involvement. You can use the basic sequences to identify the urethral involvement, for example, or you can add urographic sequences to evaluate the level of the infiltration and also hydronephrosis. Bowel endometriosis is among the most aggressive disease, and we consider bowel endometriosis when at least the muscle layer of the bowel is affected. The rectosigmoid colon is the most common location, and it is important to evaluate multifocal and multicentric disease. So in my experience, bowel prep ultrasound is the best imaging modality to identify bowel lesions. We basically follow the bowel, keeping an eye on the muscle layer because that is the most affected layer. And using bowel prep, you can have a beautiful stratification of the bowel layers and then just follow the bowel. Using MRI, you can also see the bowel layers, but as I mentioned before, you really need a dedicated protocol. Otherwise, images will be like blurry and very difficult to evaluate. We can measure bowel lesions, and we should respect the curvature of the nodules during the evaluation and provide the distance to the anal border. We use the peritoneal reflection as a landmark. And using MRI, you can measure the distance directly. So let's see the imaging characteristics of bowel lesions. They have a very repetitive and emblematic appearance on ultrasound and MRIs, the mushroom cap sign. And we can identify muscularis infiltration and also when the submucosa is infiltrated using both methods. But ultrasound is really the best imaging tool here. Again, just demonstrating the bowel layers affected here. The mucosa is rarely affected. And bowel lesions, they are eye-catching and really difficult to miss using TVS-BP. You just have to follow the bowel, and then sometimes when you see one bowel lesion, you just keep following the bowel, and then you can identify another bowel lesion. And sometimes using the transabdominal approach, you can have another bowel lesion in a higher location. And we use 3D just to emphasize the C-shaped or the mushroom cap sign. Using MRI, you can also identify bowel lesions very well, especially when they are between like 2 centimeters, 2 to 5, but lesions that are smaller than 1.5 centimeter, they are a challenge using MRI. And to identify these small nodules, you really need to improve your protocol. Otherwise, we're going to miss bowel lesions on MRI. And imaging studies, they are really a game changer for surgical planning, because we cannot identify just one nodule, we can identify multiple nodules, the distance between these nodules, for example, and the circumference affected, and then surgeons can decide between shaving or discoid, or even discoid or segmental resection. And here, just to emphasize how ultrasound is amazing to identify small nodules with less than 1 centimeter. For MRI, this is almost impossible. Even retrospective is really hard. And then other intestinal lesions affecting the cecum, the ileum, the jejunum, and also the appendix. The appendix is also a marker for severe endometriosis. We are, in general, they are associated with rectosigmoid nodules. Endometriomas can be readily identified even for less experienced examiners. But what I want to emphasize here when we identify an ovarian endometrioma is the location, the number, the size of the cysts, and the distance to the ureters. And also, we always add the antral follicle count when providing this description of ovarian endometriomas. And the ovarian fossa is commonly affected when you have an ovarian endometrioma, and the importance here is the distance to the urethral path. They are very, very close. And of course, assessing ovarian mobility is also important. We're going to use the same maneuver as a gentle pushing of the probe combined with an abdominal palpation to see if the ovaries are sliding nicely against the pelvic side walls. We always include tubal evaluation in ultrasound and MRI. And of course, MRI is more specific to identify the hemorrhagic components, the hematosalpinx. But using ultrasound, you can use 3D to emphasize the shape of the fallopian tubes, dilated fallopian tubes, or also hypocele. Moving on to the anterior compartment, here we're going to do the opposite maneuver. We're going to slide the probe into the anterior vaginal fornix here and look through the bladder wall from left to right, anterior and posterior. And here, the importance of imaging studies, it's because surgeons cannot assess the bladder wall directly. They have to open the peritoneal space in order to evaluate the bladder. So here we can identify bladder wall thickening, like nodules or plaques infiltrating the detrusor muscle, and also the anterior uterine wall or the vascular-uterine pouch, and then provide the size, distance to the trigonal zone, and adhesions. On MRI, bladder lesions will present the same aspect. They are, in general, they are located midline, on the bladder dome, and deeply infiltrating the detrusor muscle. The vascular-uterine pouch and round ligaments are the most common locations of endometriosis in the anterior compartment. We can also demonstrate a hypoechoic thickening affecting the vascular-uterine pouch. And look, this bladder wall is completely normal. So it's really hard for surgeons when you have this pattern affecting the round ligaments with a lot of adhesions to be sure that the bladder is not involved. So we can provide this information, like in this case, for example, the bladder is normal, and we have these nodules affecting both round ligaments. Extrapelvic sites can also be evaluated during the examination. The umbilicus is a marker for severe pelvic disease, as well the distal round ligaments, and also C-section endometriosis. That is a completely different scenario here, is generally related to implantation during surgery, during C-section. compared to the umbilicus, for example. The diaphragm, pleura, and pericardium can also be affected by endometriosis. And now we are including the diaphragmatic evaluation, not only for the ultrasound, but also for MRI. MRI is the best choice to evaluate the diaphragm and also these plaques. Superficial endometriosis remains a challenge. Using ultrasound, we have non-specific findings. We can identify these small cysts attached to the peritoneal surface or hyperechogenic foci attached to the peritoneal surface or to the ovarian and uterine serosa, and also peritoneal pockets. But MRI is more accurate to identify hemorrhagic components. So now we added a new sequence. This is a Brazilian group, a group of friends. They just published this paper demonstrating the value of this T1 volumetric sequence. And now we are adding this sequence to our original protocol just to look for these small hemorrhagic components, especially for patients with mild disease. They are very symptomatic sometimes and they don't have deep disease. We can improve the diagnosis of superficial endometriosis. And postmenopausal endometriosis is another important topic. We now understand that endometriotic lesions, they remain active after menopause. They express the aromatase enzyme and they can auto-stimulate these ectopic lesions. And here we always have the concern regarding malignant transformation, especially for ovarian endometriomas, and the clear cell carcinoma and endometrioid adenocarcinoma are the most common types. And then we recommend that these patients, after menopause, they should have at least one follow-up study every 6 months, at least to evaluate if these endometriomas are stable over time or if they are changing characteristics, and then an MRI can be added to evaluate for solid components and any modification in the cystic appearance. So this is an example of a 57-year-old patient with no history of hormonal replacement therapy. She had this very classic, typical endometrioma, both on MRI and ultrasound, and 7 years later, she came with this endometrioma presenting a solid component, vascularized solid component, and she underwent surgery, and it was like a clear cell ovarian carcinoma. So this, I saw this patient when she returned 7 years later, and it was like an emblematic case. So to have an endometrioma after menopause, even without hormonal replacement therapy, we should keep an eye on these cysts. And it is more complicated when considering hormonal replacement therapies, especially estrogen-based therapies. Postoperative evaluation is another important area where we can add a lot for surgeons. In general, we recommend that this first postoperative evaluation should be performed at least 6 months after surgery, allowing time for the healing process, because in general, they have extensive pelvic resections. So if you perform the exam 2 months or 3 months following surgery, we're going to have a lot of inflammation and healing process. Then 6 months is the ideal period. And then we can identify these fibrotic scars in areas where the disease was previously removed. And here, there is also a debate between ultrasound and MRI. Of course, we do a lot of ultrasound, postoperative ultrasounds, but MRI is the best choice because using MRI is easier to distinguish between fibrotic scars and residual disease. So let's go back to Kelly's story. 1 year after the diagnosis, she underwent 2 IVF treatments without success. She finally decided for surgery. She had a robotic laparoscopic one, so she had severe endometriosis, and they performed a radical surgery trying to remove all the endometriotic implants. 1 year later, she transferred 2 frozen embryos and finally had Donatella. Yeah. So she struggled for 6 years in order to get pregnant, had major surgery, 3 IVF treatments. So it's a long, long journey. And this is just to show you how difficult is for these patients to get this late diagnosis, to get these huge surgical procedures, and also multiple IVF treatments. So endometriosis is essentially an underdiagnosed disease. It is best treated by a multidisciplinary team, and radiologists, they now play a crucial role in the multidisciplinary care of women with endometriosis. And imaging with a clear and impactful reporting is crucial to successful care. So thank you so much for your attention. Any questions?
I do. I had a question. Thank you so much. We realize as the surgeons here, we are so handicapped without preoperative imaging. So we're truly, truly indebted to you and Lena for being so specialized, because I think as we can all tell the imaging, not only way that it's performed, but thoughtfully looked at. I also feel handicapped when we have patients coming from really far out and they have imaging modalities done by elsewhere, but we do try to tell them how imaging, such as you're going to do today, this afternoon, is really impactful. And I think it extends to expectations for these postoperative pain patients, for setting expectations, because the better picture we can paint for them preoperatively also helps them cope with their pain if it hasn't completely resolved in the postoperative period. So that kind of segues to my question is, in clinical practice, if you've communicated with surgeons, when do you feel that the postoperative imaging changes practice? And then to tag along with that, how integral is the 3D ultrasound in your preoperative evaluation?
Okay, so for those that are attending the presentation through Zoom, the question was emphasizing the role of preoperative and postoperative imaging studies for the best clinical practice, but the main objective of the question was focused on postoperative evaluation. Yeah, so I do a lot of postoperative evaluations, and of course, patients are very anxious to understand how curative, because they always ask about cure. So if the surgery was curative, if they could remove all the disease that was present in our preoperative mapping, and also regarding the healing process, any residual disease. And what is really interesting to comment here is that we all had a learning curve in Brazil, because we started these specific protocols in 2001 at the University of São Paulo. And then I think we all learned, we had a huge impact on residual disease, because before these specific protocols, we had a lot of patients with residual disease, especially subperitoneal nodules. And then as long as the surgeons were like comfortable with our reports and they were trusting in our information, then they went like deeply and removing this tissue, removing disease located under the peritoneal reflection. Then we can see a huge impact on residual disease, minimizing residual disease, and also surgical scars, because they can plan the surgical procedures ahead. They can involve a colorectal surgeon, sometimes a urologist. So I think the post-operative evaluation is becoming more and more easier for us, because surgeons are getting much better now. They are removing all the disease, and then we can like confidentially report surgical scars or any other anatomical change that will come after radical resection of extensive disease. And also we can reinforce, for example, when they decide to leave disease behind. So these patients, sometimes they decide to leave myometrial infiltration, ileal nodules, sometimes they don't remove it, or even for bilateral endometriomas for patients that are young and that they are trying to conceive. So we can follow up them, we can control these findings throughout the years, and it is something clear, transparent. They are all sharing decision making. So I think it's everything works better when they are well informed about their conditions. And they patients, they are, in general, they are very engaged and involved in their decisions regarding resections, surgical resection or extensive resection, or even to decide about the need for egg freezing before surgery. Because now surgeons can demonstrate, for example, bilateral disease, ovarian fossa affected, and also a low antral follicle count, and then they can counsel patients regarding the need for fertility preservation before surgery. You're welcome. No further questions? Yes.
Standard imaging screening. This is a lot of patients follow up on my endometriosis.
Yeah. Okay, so when we started the SRU consensus, I think I was the only one who was fighting to recommend the SRU consensus to all women, not only for symptomatic patients, because in my practice, I see women like from adolescent until postmenopause, and we can have a lot of patients with severe disease and no symptoms. That's why we don't have a strong correlation between disease severity and symptoms. It is unbelievable. Sometimes we have patients with complete obliteration of the cul-de-sac, 2 bowel lesions, vaginal nodes, and then you ask patients, do you feel pain during intercourse? No. Do you feel? It's unbelievable. That's why I think as a screening test, I was trying to push the group to recommend the SRU consensus to any kind of patients, symptomatic, asymptomatic. But then I think the idea is to have the routine ultrasound as a screening test. I think we should always include the heterocervical evaluation, because this is the most common location. It is rare to have endometriosis affecting the bladder, the bowel, without heterocervical disease. That's why heterocervical disease is almost like 90% of patients will have disease in this area. And then when we identify heterocervical disease, we can recommend dedicated protocols, because the idea about the dedicated protocols is just to have a mapping. These patients not necessarily will need surgery. If you identify a bowel lesion, they do not necessarily need a bowel resection. We have a lot of patients under follow-up studies and using contraceptives or any other medication or even IUD or no medications, but we can follow up then. I think the main idea for the dedicated protocols is to have a map and then counsel patients. It is a very like patient-centered approach. Will depend on the age, the symptoms, and if they are trying to conceive or not. That's why counseling is so patient-centered, and that's why they love these drawings, especially patients, because it reinforces their symptoms, their complaints, and they can just follow these findings throughout the years.
How often after MRI imaging do you add the ultrasound? That's very specific protocol.
Yeah. So how often we add MRI to the ultrasound? I would say that which method you can perform, it will depend on how experienced is the radiologist. Yeah. In Brazil, for example, in São Paulo is heavily based on dedicated ultrasound and MRI. But in Rio de Janeiro, for example, we don't have specialized radiologists working on bowel prep, but we have excellent radiologists working on MRI. So it will depend on the availability. In our scenario, for example, our surgeons, they always ask for the bowel prep ultrasound. And if the bowel prep ultrasound can provide a comprehensive mapping without any limitations regarding the size of the uterus, multiple leiomyomas, multiple ovarian cysts, if the radiologist feels that he could have a comprehensive evaluation only using ultrasound, we're not recommending MRI. And then most of these patients will undergo surgery only based on bowel prep ultrasound. But sometimes due to the health insurances and all this bureaucratic process regarding surgical approvals, they sometimes ask for an additional MRI to confirm the findings and to have a multi-compartmental evaluation. And I think when you have bilateral heterocervical disease, large nodules, you can have neural infiltration, and then MRI will be very useful. The ideal scenario would be both methods. Yeah, but sometimes it's difficult.
I appreciate what you were just saying with the previous question and comment around imaging as a way, especially the post-operative imaging, as a way to have more trust with our patients. I feel like, learning more and more about endometriosis in the community of folks who suffer from it, there's very low, I think, trust within the medical system because, as you pointed out, it has failed, women for decades of their life, and then they end up in this kind of like crisis mode. So I really appreciate that. So just wanted to bring that up. Yeah. And the second question may not be for you, maybe for you guys, but anyway, I can answer it. I'm remembering from residency around times of what was it, the rate of transformation for endometriosis, like you said, 1% to 2%. Yeah. Does it change? Is it higher with postmenopausal? I'm assuming it would be. So my question is, should we just be removing those and not following them if you see them in a postmenopausal patient? I just gotta look. I'm not, I'm not advocating. I don't know. I'm just going by that case that you put up there, and I wonder if that needs to be like that. I don't know.
Yeah. I think one of the questions is, do people who have a stable endometrioma, asymptomatic, enter menopause? Should those continue to have surveillance? I think that based on the information, there's this risk of transformation that's higher. We talked about this last night. I think that they should continue to be surveilled.
Definitely
we should not.
My question
is, should we remove it? I don't know. Because it's low. It's low.
It's still low. So it's higher than the 1% to 2%, but it's still low.
And that, the patient that she brought up, she was lost to follow for 7 years.
Yeah, 7 years. Yeah.
Okay.
Yeah. yeah, I think at least we should keep an eye and follow up these cysts. Yeah, it is interesting. It is interesting to learn about this. That endometriotic lesions, they remain active. This concept of aromatase enzyme feeding this, auto-feeding these lesions is really interesting, because people in general, they counsel patients saying that, oh, post-menopause endometriosis will be like a scar tissue, not active. And sometimes these patients can present pain, chronic pelvic pain, 10 years after menopause, 10 years. Yeah, so they can become symptomatic again. It is.
But I do think it's worth counseling patients for removal. If they have I think it's worth counseling them, because some people do have a high risk aversion. Right?
Yeah, and then, imaging every 6 months, I'm also thinking about like insurance and being lost in follow-up, like yeah.
I think it feeds into learners too, just saying that even though theoretically with all the hypotheses of why endometriosis comes about, postmenopausal women are often coming to us and being told like your endo will get better, just menopause, and that's but it's also so case dependent and requires a specific conversation that is addended with imaging, not just discussing their symptoms. So we need that to reinforce what might not happen with their disease.
Yeah.
So, that's great.
Thank you.